So we are the CSP Southeast Coast Regional Network, and you have me and Sarah Jane from the Southeast Coast Regional Network here with you today, and supported by the very abled Amelia Sutton. And we are a committee of physios across the NHS and private sector based in the Southeast. If you have attended our previous Physio Grads series sessions, we are delighted that you benefit from these to join us again in our 5th session. If you've missed some of those, then we have recordings up. And today we are delighted to be joined by Natalie Andrews and Rachel Ellis. And these experts will be providing advice and hints on answering interview questions, primarily related to the field of community falls. We will be recording it, and all these recordings will be available shortly after they've taken place. We will use both the chat and the Q&A today. Use the chat for any interaction that is requested during the session, as will be by our speakers. And please use the Q&A for any questions you might have, but we will pick them up preferably towards the end of the session. So welcome again, one and all. Thank you for your precious afternoon, and feel free to have lunch while you learn. And I leave you in the capable hands of Natalie to start with.
Hello, apologies you got me side on. It was only where I could get my camera and the PowerPoint to share today, so apologies for that. So first of all, just to introduce ourselves, I'm Natalie Andrews. I qualified as a physio over 24 years ago. I spent the first 4 years of my career in the Acute Hospital Trust doing rotations as a band 5 and 6. Then I specialised as a band 6 in the field of community rehab in 2006, where I then became the physio lead for the team and then the team lead for the whole MDT. And then in 2020 followed my passion, which has always been falls prevention, in this role for rehab and therapies for East and West Kent for KCHFT. I will pass over to Rachel in a minute, and who also talk about her role and also why working for KCHFT is brilliant. I would just add that I am part-time and have been for the majority of my career, and the things I love most about that is the flexibility and like homework balance.
Lovely. So I am Rachel Ellis. I qualified 22 years ago. I spent the first 15 years of my career in the acute hospital setting, rotating around at band 5 and 6 level before specialising in elderly care, frailty world, and moving into a clinical lead physio role for planned care. I then took a leap of faith and came out into the community, which was definitely different, but was great different opportunities. So I was the lead for the community rehab team in West Kent, and I'm now an operational lead in a slightly more management role. From a community trust perspective, just a little bit of a plug for us while we're here. I think it's often expected that your first jobs will be in an acute trust, doing your rotations, because that's just what you do. And it's just to say that actually, you know, we're out here in a community world as well, and we can offer as much, if not different, to acute trusts. So we still get very involved in all different areas of physiotherapy. So there's neuro, there's general rehab, there's falls, there's children's learning disabilities. We get involved with patients right from the beginning of being proactive, trying to prevent things from occurring, and that proactive care right through to the managing long-term conditions and through towards the end of life as well. I think one of the most rewarding things about community work is the fact that you have flexibility. Yes, it's probably a bit slower because you have to travel between the patients, but also the fact that you get to step into that patient's world. So in our hospital, you're there in your world, but in the community, you're in theirs, and you can really get engrossed and embedded in trying to support them to achieve what they want to live a better life. So anyway, now I've done my plug, we'll move on to why we're here. So what we're going to go through today is some general hints and tips, and then we're going to look at a mock falls interview question. Both of us could probably talk about falls all day if you let us. So we're trying to break it down into different sections and simplify bits. Again, as I said, because we could talk forever, there is some parts of this where we've just put in resources that you could go away and have a look at in your own time, or come back to at a later date if you suddenly thought that you wanted to know more. Because we can't get everything in all at once. So let's hear from you first, if you're happy to. So can we just get you to write in the chat what sort of things are you hoping to learn from today's session about falls questions? Chat silence. And the other thing we're keen to know is currently how confident you feel about answering questions about falls in the community. So if 1 is not very confident at all and 5 is highly confident, where would you put yourself now? Fab, will definitely be talking about the assessment for the first part of our question, for sure.
So you've got another one. Ramina has come in just saying she's probably feeling around a 2-ish in terms of her confidence levels.
Fair enough. So 2, 3 around that round. So hopefully we can up that for you with the bits that we've got to share with you today. Fab. Okay. Let's crack on. Okay, so this slide is just some general hints and tips. You've had a previous session which is on the website, and you can go through the link and have a look at. So we're not going to kind of try and recover all of those sorts of things, but our key initial tips for any question would be break down the question, particularly if it's a scenario-based question. Think about all the different elements of what that scenario could hold. So you need to talk about probably what you would assess, your clinical reasoning. If you can reference any evidence-based practice or guidelines, throw in a bit of NICE or something like that, then that was extra brownie points. Try and relate it to your own skills and experiences. So we accept that you're newly graduating physios, so you're not going to have done everything already. So if you can say it was a little bit like the patient that I saw here, and relate it back, then we can see how your brain is thinking. So that's always good. If you can relate anything to the trust of the team that you're applying for, again, extra brownie points. You know, for example, do we run a falls program, or do we refer on for that? Or do we have a neuro team, or do they just do children, or do they do adults as well, etc. And then if you know anything about what's happening nationally and things that you can get from the fabulous CSP, then that's good too. So community-wise, again, just a little bit of a generic update. What sort of questions, if you came to a community interview, would you expect? Well, there's going to be loads on falls prevention and post-falls interventions. Frailty and deconditioning is also a huge part. You've got orthopedics, some stroke, so neuro, etc. And then there's the things around sort of prevention of any kind of long-term conditions or reducing risk. Supporting hospital discharge. There's always going to be a triage question or something where you're given a set of patients and you have to say, well, what order would you see them in, or who would you have to see first? And then something about how you'd measure effectiveness and outcome measures is usually thrown in there. If you're asked a scenario-based question, then we're looking at a variety of things. So how do you communicate what you're trying to say in the first place? Are you considering the wider MDT? So are you thinking about who else you could use? You don't have to be able to do everything yourself, but if you can think of those other things that you'd ask colleagues for, that would be brilliant. Thinking about lone working, what you do on your own, and what things you'd need to escalate. So if they're asking about a question where something's gone wrong, then do you need to escalate things? What things are you going to action yourself? And then also there's usually something out there about time management, the fact that we have to be able to get from place to place and write our notes and factor everything in is a challenge for us. So the aims of today's session: to increase confidence answering an interview question relating to falls. Particularly we've gone for the community, so we're looking at someone who's in their own home at the point at which this is happening, rather than somebody who's on a ward. And the differences that brings in, and we'll try and relate it back to the national guidelines for you and increase your knowledge of when a falls assessment's indicated, what factors you'd include in your falls assessment. So hopefully that covers what the person in the chat was after. And then those falls management options, potential treatment strategies, and who you can refer them to.
Okay, we would have loved to have obviously had more time to talk about some additional questions regarding post-falls, but obviously we didn't have time in the 1 hour slot. So what we would say is always be prepared for maybe an emergency scenario-based question in the community. Because you are alone working, you will come across some emergency situations, and we in particular want to know about your escalation skills and knowing when to seek extra help. So in terms of falls, post-falls might be a question. So in particular, maybe revise common injuries, signs and symptoms. So things like a fractured knob, is the leg shortened, externally rotated, etc. Also about when you would escalate. Our patients are vulnerable. They're normally housebound and live on their own potentially. So we need to know when to escalate your concerns and the timeliness of this. DNAs. It's very different someone not coming to a clinic versus you going to the home of a housebound patient and them not answering the door, because straight away, if you know this patient doesn't normally go out and about, alarm bells might start ringing. Has this patient had an event and they're lying on the floor waiting for you? So you might have a question about what would you do if you knocked on the door? What would your next steps be? Trusts will have policies about this, commonly called no access policies. So it's worth having a refresh on those. There's loads of resources about post-falls. Again, I'm sorry we haven't time to go through it, but you will get all these hyperlinks on the slides when the CSP upload them onto their page. So you can go away and have a look at all of these useful resources on post-falls and what to do in the event of a fall. So today we've been asked to prepare you for a typical community falls interview question. So today we thought we'd use a scenario-based case study. It is a particularly vague question, and that is intentional because quite often referrals in the community are vague. You'll get just, please see this patient for mobility, or patients had a fall, please review. So we have kept it very generic. So the question we're asking you today is, you're working for the community rehab team and Mrs. Smith, who's an 80-year-old, is referred by her GP due to falls. So what assessments would you complete to try to understand why she's falling? And then what advice or treatment would you suggest to best manage her falls? Obviously, it's quite a large question, but we thought today what we'd do is break it down. So although the question and the interviewer will not break it down for you, it's a good way to structure your thinking is actually to take this question in bits. So we're going to look at the assessment side of it first of all, and then go on to the treatment. And after each section, we'll ask you to have a thought and put some of your thoughts into the chat about how you would tackle this question. So going back to the original question, we're going to tackle the first part, which is assessment. So what assessment should you complete? So within this, the interviewer will be looking to mark you on whether you know when you should complete a falls assessment. So this would show awareness of evidence-based practice and guidelines that are out there nationally. And we'd also like to hear about what outcome measures you might think about, particularly in this specialism. What's good, what's not so good for falls prevention. Sometimes time's quite limited, especially in the community. So sometimes you need to think about must, should and could. So think about in this answer, making sure you've definitely covered the must parts if you don't have time to answer all of it. So in the chat, if you can just write what assessments you think you should complete with Mrs. Smith. Rachel, I'm afraid I can't see the chat, so if you don't mind being my eyes and...
You've had Ramina has come in with the must. Assess her surroundings, look out for clutter or obstacles, assess for mobility aid requirements. You've got Alana coming in with risk assessment.
And any outcome measures? Anybody know of any outcome measures we might use in this area of falls?
Becca's come in with Berg balance.
Yep, so Berg balance is one. Typically in the community, our patients are housebound, so Berg isn't one we use very often because that's quite high level balance. If you were seeing someone, for example, in a clinic or someone who is more independent, then Berg definitely. Some of our patients, we will use it, but I would say the majority of our patients are too frail to be able to use it.
4-stage balance.
Yep.
You have
Lovely. Frailty scale. Yep. So Watford is the one that we use within our trust. Up and go. Yep, we use that one.
You have the false frequency as well. That's come up.
Yeah, and falls history. Yep, lovely, brilliant. So when you're completing a falls assessment, it's really clearly stated in the NICE guidelines when you should do this. So new falls NICE guidelines came out in April of last year. And it's a really hot topic of discussion, particularly within the community trust, because they have changed the criteria for when a falls assessment is indicated. They have now 3 sections within the NICE guidelines: hospital, inpatient, care home settings, and then community. And obviously today we're just looking at the community. There's a flow chart which is probably too small for you to read, but it is a screenshot from the NICE guidelines telling you exactly how to screen to show when a falls assessment is required using their new criteria. So if you have a look at that after today. As I said, we today are looking at the community, and we're going to be talking about falls assessments, which are commonly called the MASA, or the MFRA is also another term used. So MFRA was what it was traditionally called, and it's now changing over nationally to MASA, which stands for Multifactorial Assessment to Optimise Safer Activity. It's a bit of a mouthful. So the outcome measures we've discussed a bit earlier about your thoughts in the comments. So on the screen are the ones that we commonly use. You will find that different services and different trusts might have different KPI targets to complete different outcome measures. So it might vary from trust to trust, but these are the ones that we commonly use within KCHFT. Okay, so now we've looked at when to complete the assessment. We would like you to show the awareness of what kind of things you would include within the assessment. So different falls risk factors. Can you put in the chat different risk factors that you think you would need to look at? Obviously, in the community, it's really important that we're involving the patient. So our focus of the assessment will always be not what the physio thinks is the priority, but what the priority is to the patient. And actually what we see as a problem, they might not see as a problem. And their goal might be very different to our goal. So it's really important that obviously you include the patient when you are doing some of your assessments and goal setting. So if you could just pop in the chat what risk factors you're aware of for falls assessments.
We have polypharmacy from Madeline, blood pressure, fever, Ibrahim, presence of other comorbidities, other health conditions.
Any more? Nope, I'll carry on. More might come, or you can carry on adding them as we continue. So there are actually hundreds of risk factors for falls. I think one article said there was over 400 individual risk factors. So obviously we can't go through all of those, and they commonly get grouped together. On the screen, you'll see a summary of the falls risk factors, NICE guidelines versus the World Falls Guidelines, and you'll see that they are practically the same, as we would hope they would be. The ones that are commonly missed are lying and standing blood pressure and bone health screening. So if I'm interviewing and you say that, you always get a big smile from me because they are common ones that people tend not to remember. The RCP website also has lots of really useful information about what constitutes a high quality MASA. So not just what to include in it, but how to make it a good quality assessment. So it's worth having a look at that. Although the RCPs is targeted at inpatients, a lot of it is transferable to community. So please have a look on the link on the screen. So next we want you to show that you're able to analyse your assessments, so using your clinical reasoning and differential diagnosis skills. So in the chat, can you put your thoughts about what would you then be looking at from your assessment to try and establish what the possible cause of her falls is? So what would be your differential diagnosis? What could be causing it?
We have gait issues.
Some of the other things that came up earlier were about lighting and environmental hazards to balance.
Yeah.
Physical health issues, UTIs, home environment, environmental factors, stroke, muscular weakness due to medical issues.
Good. So some medical, some kind of more traditional physio, you know, muscle strength, balance, etc., and then some things that are external, such as environmental. So the possible causes of fall on the screen, obviously, again, there are hundreds. So these are just the most common causes of falls. I'll leave you to read through all of them. It's really important that when you do a falls assessment that you get a really clear history of the falls, and that includes near misses. And then common factors tend to be things like footwear, environment, medication, balance, etc. There has been some research into the risk factors and which actually increases your risk of falling the most. So, for example, muscle weakness increases your chance of falling by 4.4 times. Obviously, the thing to bear in mind is the majority of our patients in the community are frail and elderly, so they're living with comorbidities, and so they'll have more than one of these on the list. In fact, some of them might have all of them. So obviously their risk of falling will be cumulative. So there's never, ever normally one cause for why they're falling. So you might also get a scenario-based question for your interview about acute falls. So, for example, if I then changed the question and said, Mrs. Smith has had 6 falls in the last 24 hours, what are your thoughts? Obviously, the interviewer here now wants you to demonstrate awareness of the common causes of acute and frequent falls. So they tend to be more medical in origin. So you would be expecting you to think, well, maybe they've had some kind of medical event, maybe a stroke, or they've got an underlying infection. So again, you would need to know the signs and symptoms of things like an infection, like a UTI, and then when to escalate and request an urgent medical review. So just to say that might come up as an interview question as well, so be prepared for that. I'll pass you over to Rachel.
Lovely. So now we come on to the second part of the question. So and what advice or treatment would you suggest to best manage her falls? So we've looked into why they're happening. And now we need to look into what we're going to do about it and the clinical reasoning for that. So what do you think the key areas that we would need to consider when we're thinking about what we could do as physios to best manage falls? Absolutely. Education and advice is a really good one. Anything else? Exercise. We're physios. We're exercise prescription for strengthening and balance. Absolutely. An increase in muscle strength for sure. Anything else? Home setup. Absolutely. So considering the environment of the individual. Walking aids I saw pop up there as well. So any equipment that we might be able to consider. Assistive devices, yeah. Referral to OT, like it. Think about the MDT. Fabulous. Okay, so if we move on, the key themes that we came up with were exercise. Let's big ourselves up as physios first, hey? And the things that we can do about that, and making sure it links back to the reasons that they might be falling. So is that exercise for balance? Is that exercise for muscle weakness? Is that exercise for, rehab from a trauma or an acute episode of something? Advice and education, absolutely, that came up first, didn't it? So falls prevention advice, and how to make sure they're reducing the risk of falling. So they've come up with all these risk factors that people may have and talking them through how they can modify that themselves, because we can't be there all day every day, and they are at risk of falling all day every day. So what can they do to make themselves safer and to reduce the impact of the risk factors that they have? Environmental changes, so reviewing their home environment or the environment with which they live, and thinking about if there's anything we can do to change that. Equipment, so is there things that, you know, assistive devices or walking aids or anything like that that we can give them that can modify things that they're doing to make them safer. Thinking about managing ongoing falls is another thing. It comes into the falls prevention and advice section really, but thinking about the fact that for a big cohort of the patients that we will come across, we are never going to stop them all from falling. So there's that advice and education around, okay, so I have fallen, what do I do now? How do I get up from the floor? How do I call for help, etc.? And then, yes, absolutely, your onward referrals and thinking about the other people in the MDT. So we've talked about in the chat, you've talked about the OT for reviewing their care intervention. You've talked about GPs for medication reviews. They're all great suggestions. But always thinking about that MDT is a really valuable thing and makes you look like you've thought beyond yourself.
I was going to say, just interject, obviously, because we are seeing them in their own home, sometimes consent can be a challenge. So we can give all this advice, you know, please remove your rugs, etc. But it is their home, so consent can be a challenge, and that's why it's important that we consider things like mental capacity, etc. So again, you might possibly get a question come up regarding that as well.
Yeah. Okay. So again, it's thinking about breaking down the question when somebody is asking you something that's quite vague. So what treatments would you suggest to best manage this patient's risk of falls? So that's thinking about what risk factors can you reduce with things that you can do. You've then got what advice would you give to the patient and or the carers or the next of kin, etc., regarding their risk of falls. So that's about the information and the onward referring and the signposting. And then the who could you refer to is about your use of the MDT. So firstly, what treatment? So if we're thinking in the realms of what exactly can we do, I think, to be honest, you've given me most of these already. So we'll keep going. Exercise, awareness of evidence-based practice and linking it back to something that's gold standard is always going to be an excellent thing to be able to do. And thinking about, again, what does that trust or team that you're applying to offer? We go into a bit more detail about exercise specifically in future slides, so we'll come back to that. But also the other thing that we can do, so we can do exercise and we can do equipment. So thinking about walking aids, if we're able to improve the steadiness of their gait with a walking aid, are we reducing the risk of falls? Thinking about the types of walking aids that they're using, it might be that the walking aid they're using is what's causing their problem, because they're trying to use something that you need to use two hands on and carry plates and things around their house, so they're only using one hand. And are there things we can do to modify that for them? Or is it a case of actually they're using something that's only in one hand and they need to have two hands on it to increase their balance sufficiently enough to make them safer? And then thinking in equipment terms about activity modification. So are they falling when they're trying to do something specific? And how can we support with that? Can we put a perching stool in their kitchen so that when they're trying to cook and not hold their walking aid, they can sit down and do it? Same when they're maybe in the bathroom. Is there something, I think people have talked about assistive devices, when they try to sit to stand, they're just not able to do that part of the activity and they get too stiff and they're toppling over, or they can't push up effectively. So are you looking at things like, you know, riser chairs or raising sofas with blocks, etc. So this slide is a bit more about the falls guidelines and treatments and exercise. It's things you can have a read of in your own time, really. There's lots of guidance out there in terms of what exercise is the best to do. There's the NICE guidelines, world guidelines, NAIF, I can never say that properly. There's also physical activity guidelines from the government. So this is a nice visual of some of the things that, you know, they advise you do to reduce your chances of becoming frail. And then this next slide here is more about the, okay, so what exercise is actually effective? in terms of falls. So there's common falls exercise programs that are out there that have been written specifically for this purpose and this cohort of patients. So you've got things like Otago and the falls management exercises and the Tinetti programs. But there's also the more generic advice about the fact that, what is efficient and what's actually going to have a lasting effect. So it's about the fact that these things need to be quite high dose. They need to be at least 2 hours a week for 6 months. They need to be 3 times a week, ideally. You need to give them enough time to rest in between, but also making sure that your programs are focused on the right elements. So balance exercises need to be challenging enough. You can't just do static balance exercises with an individual and then expect them to have the same level of balance when you're then asking them to move or negotiate uneven surfaces, etc. So you need to have a variety of static balance and dynamic balance. And then in terms of your strengthening exercises, you need to be a little bit specific about what you're trying to achieve. They need to be targeted. So have you got leg strength, weakness particularly, and therefore you're focusing there? Is it more global deconditioning that you need to target? It's good to have a resistance element in, so adding some kind of TheraBand or light wrist weights, ankle weights, things like that, and to try and make sure that programs are progressive. Falls programs are supposed to be for quite a prolonged period of time. Therefore, if you just do the same thing over and over and over and over again, then you're going to get more used to it. You need to have them getting gradually harder as you go through, and make sure that you're combining endurance and strength in terms of how you're exercising your individual. And obviously everything has to be individualized to the person. You're not going to do exactly the same program with someone who's fallen once or twice but was quite active as you are with somebody who is much frailer and struggles to get kind of room to room in their house but still has a high falls risk. So it's just trying to make sure that you're thinking about the evidence but also about the patient. So the next thing is, what sort of advice are you thinking about giving to patients or next of kin regarding risk of falls? Any thoughts about what sort of things you might be telling them? No. So some of the advice you give is going to be about what you're asking them to do. Some of it's going to be about their exercise and how much they need to do to see effect. Some of the advice, could be around the use of walking aids, absolutely, and is going to be around the things that you are giving them. So environmental, is another good thing. So environmental is quite a big one, particularly if you're in the community and you can see the things that may need changing. So within somebody's environment, those conversations aren't always easy to have because they're very attached to the rug that they got from China when they went there in their youth, for example, and they don't want to move it from just in front of their chair where they trip over it every single time. But it's trying to have those realistic conversations with them. So talking about, are there things that they're tripping over that they could move? Can they mount their beautiful rug on the wall instead so they can look at it rather than trip over it? Can you go down the line of looking at, lighting, where the furniture is? Have they got enough of a path between places that they need to get to within their house? Someone's put in the chat about pacing. Absolutely. Is it to do with the fact that they're getting fatigued that's causing their falls? And then do they need to be able to pace themselves and or plan their routes to things and have regular places to pause and rest? Reiterate the importance of exercises for strengthening and what that can do to improve their confidence. Taking their time when getting up from the chair, absolutely, instead of doing things in a rush. It's about that self-management of falls and the advice you are giving them about that. The other thing that can be quite helpful is making sure that you're being honest with them about their risk of falling again. So some of the educational advice we'll give them is about improving their current status. And some of it is going to be about having that frank conversation about the risk factors they now have, and which ones you can and cannot change, and which ones they can and cannot change, and then having another conversation after that as well, which we come to in a minute. The other thing we can do in terms of information we can give and advice we can give is signposting. So signposting to things that they can access. So somebody's put about pendants alarms and falls alarms. Yeah, absolutely. Things they can do to make themselves safer, to call for help, etc. We also will give quite a lot of information generally. So as a trust, we have quite a lot of leaflets that we would give out that touch on some of the kind of less physio-y risk factors. So for example, we have some that are around diet and falls prevention, you know, the right sort of things to eat and drink that will make a difference. One's about footwear, and which footwears are higher risk and where they can get ones that may be more appropriate. Foot care is another one as well. So kind of basics of some of our podiatry colleagues and being able to refer on to them sometimes if we need to, because sometimes, you know, our diabetic patients, etc., will struggle with their feet, which are essential for walking and balance. And then we have information as well around postural hypertension. So somebody said about making sure that you take time when you get up, and sometimes falls can come around as a result of this drop in blood pressure. So your postural hypertension, when you go from one position that you've been in for a long time to another, and your blood literally sort of, you know, rushes to your feet. So yes, again, you've got advice around there about, okay, move in stages. Don't just stand straight up and rush off to the toilet. Let's take our time. Let's go from laying back in our nice recliner chair to perching on the edge of it. Then let's just stand up, but just give ourselves a minute or so before we then move off, etc. Environmental factors, there's loads. Some of them have come up already. So some of the things that we can advise about are kind of orientation within our environment and making sure that we're aware of where things are and what's causing our threat. And we've talked about footwear and clothing, hazards of rugs and clutter, etc. Lighting, simple things like making sure things are where you can get to them. Your walking aid is not left on the other side of the room, and you have to walk the whole way across to get to it before you can hold on. For example, making sure the heights of things are right. So again, someone said about struggling to get up, and that can be quite simple way of making things safer. And then you've got your modifying equipment, so things like your handrails. So are they slipping on a step, or as they go through the entrance to a property, or as they're trying to be in the shower where it's obviously wet and therefore a higher risk environment. So can we put things like grab rails, etc., up to reduce that risk? And then obviously in some patients you would have risks to do with how their homes are decorated or how their flooring changes. For example, your Parkinson's patients will sometimes freeze at door thresholds, etc. So you can give advice about things like that. Okay. We can't stop all falls, which I said before, and so we have to set realistic expectations, and that's quite challenging, and that's where it's quite nice to bring into kind of some communication and negotiation into your answer. You know, if patients are coming up with things that you're trying to tell them things that they might not enjoy hearing, then you can throw in how good you are at negotiating and how you can teach them about why it's good for them, etc., and how you can use their family to try and encourage them or make it about their goal and what they want to do. But also some key things for us to do are some advices for the what if. So that kind of post falls advice. You are going to keep falling over because some risk factors we can't change. Therefore, let's plan how you call for help when you have fallen. So have they got that lifeline and the pendant alarms, or do they have a mobile phone that's always in their pocket? Or do they live in a wooden control flat with a pull cord, etc.? So that's how would they call for help if they have fallen? Is there a plan for how to safely get them off the floor? So can they get themselves off the floor? It seems quite counterintuitive sometimes to put a falling patient on the floor, but actually you need to put them there to see if they can get up, and you can teach them those things like backward chaining and how to get themselves off the floor, or you've established that they can't, and then it's the the advice around, okay, if you're a frequent faller and you can't get yourself off the floor, but you can call for help, but it's going to be half an hour, then have you got a blanket or something low level that you can pull down into and make yourself comfortable while you wait for help, so that you're less likely to get cold or, you know, have some of the risk factors of a prolonged lie. And then other things that we can look at are, if people are frequently falling, is there ways that we can get them off the floor safely if they can't do it themselves, that will help their family and reduce the burden on emergency services and being constantly admitted to acute hospitals or picked up by ambulances. So we have things, lifting cushions, often called elks or camels, depending on the size of them, that you can have in people's homes. So they're things that as therapists we would often assess for with our, sometimes just as physios, sometimes with our AT colleagues, we would go out and have an assessment of whether they can use those things, and again reducing the risk and making the patient safer, so they don't long lie. Okay. Other equipment you can consider, I think I've talked about most of this already. So lifelines, falls technology you can have. In some places you may have people who are themselves less aware of when they're going to fall. So they may have some cognitive impairment, for example. And in those individuals, you might have sensor mats or technology that will alert somebody else when they've fallen, when their level has changed, or when they've moved, or they come off the chair, etc. You've got your lifting cushions, which we've talked about, and then you've got things like people who may fall out of bed, and that might be something that happens frequently, not something you can stop. So you think about low-level beds and crash mats and rails, etc. And how do we reduce injury in those people that are going to fall? So are there people that might need some hip protectors? Sometimes people will have soft helmets that they will wear if they're really frequent fallers, for example. The last bit really is, who could you refer on to? So there was some thoughts went in the chat before. If anyone has any other ideas, then please add them in. We have the OT, who you were going to talk to about environmental and equipment. We have the GPs, who you were going to talk to about medication reviews or reviewing medical conditions. Other things that you might refer through to, we might use podiatrists, we might use social care, if it's a case that they just need more help and they're trying to do too much. We may need our nesting teams, etc. So there's lots and lots of people that we can refer on to in our world and share the rehab with. Have I missed anything? Oh yeah, audiology and ophthalmology. So eyes and ears are key for balance, aren't they? Dietetics for nutrition, etc. And then there's also other charitable organisations that we can consider that might help with things. So things like the KAB, who the Kent Association for the Blind, do things and different types of falls technology, etc., for individuals that they can use. And then there's also ongoing exercise. So can we refer them into any community exercise programs with our voluntary care sector, for them to keep doing things, because we can't see them forever as healthcare professionals.
So that brings us to the end of our slides. So before we go to the Q's and A's, I just quickly want to share with you the resources that you will have available to follow the hyperlinks later on. So these are national resources and evidence-based practice guidelines, also links to the services that we provide here at KCHFT. So in case any of you have got an interview coming up at KCHFT, there's a bit of information about our teams, just to make you aware that things are commissioned differently in East and West Kent. So if you do go on our page, just make sure you are selecting the correct locality for where your job vacancy is. We do have different groups as well. So, you know, if you are coming for an interview and you want to come and shadow one, maybe you can always ask whether or not you can come and have a look at things if you did want to find out a bit more before your interview. So that brings us to the end. Thank you, obviously, for listening and coming today. and for all your engagement in the chat. Apologies I couldn't see it, but thank you to Rachel and Vina for reading those out for us. We hope it has been useful and that you feel a bit more prepared for the type of questions you might get if you do come to the community for an interview. So if we could just go back to our original question, which was how confident do you feel if you were going to have an interview question related to a patient who's had a fall? If you could just go back to your scoring and now rate from 1 to 5, 1 being low and 5 being very confident, just to see if there's hopefully, fingers crossed, been an improvement. And then we will obviously go over to Vina or Sarah Jane. Are you finishing today's session? And then we can do Q's and A's. Yeah.
You have an amazing 5 there from the sort of 2-3 ballpark. You are now at 4 5s. So well done to both of you. Thank you. Lovely.
Brilliant. Thank you so much. And people keep putting your thoughts in as to how you're feeling. It'd be really useful. And you're getting loads of thanks, as Vina said, for a great session. Really useful, Natalie and Rachel. So thank you for giving up your time. Just before you all start popping off the call, can I just flag to you the great kind of support the CSP has put in place to support our graduates and our soon-to-be graduates, because I know there might be some students on the call as well. So please do look at the graduate support package and join your local region of the CSP. So we're the South East Coast, and you're very welcome to, if you're in this region, to join us and get involved with us. But do join your region for wherever you are based, because they can continue to support you as you're striving to get that first role. For those of you already working, then we hope this was a great revision. And for those of you soon to be graduating, we also hope this is very helpful to you for your placements. Could we go on to the last slide, please? So this is just some feedback we'd ask of you. If you don't mind just going to Menti or clicking on that QR code, just to give us some idea of how you found the session and anything we can do for future sessions. Whilst you're doing that, just wanted to remind you of our session tomorrow evening, which is focusing on a stroke patient, if you're interested in that one. And we are hoping to organise one in the next couple of weeks that will focus on a Parkinson's patient. And as Vina mentioned at the start, please do take a look back over our other sessions we've run. So we have a general interview one, an MSK, and a cardio-respacute one. So thank you very much, everyone, for coming along. Don't forget to leave us some feedback on the Menti, and see you tomorrow for those who can come along. Take care.